Hey guys, welcome back to the other half of altering dose regimen. Last time we talked about when we would want to change dose rate. Today, we're going to talk about when do we want to change our dose interval. Keep in mind that we still have no control over clearance, volume, or bioavailability. No way, no how can we change any of this. So, when one of these changes and affects our dose regimen by either increasing or decreasing, what we can do is change our dose interval or our rate. But today we're going to focus on dose interval. Just like when we talked about dose rate, the first question we have to ask ourselves is our PT clinically acceptable? Is our peak to trough ratio where we want it? For certain drugs, you're going to want to target different peaks and different troughs. Now, when we look on this graph here and we look at the max and the peak here, if this is not where we want it, we can increase or decrease how frequently the patient is getting to change where our max and our min is. If we give it more often, and please don't mind this horrible drawing I'm about to do, our max may only be this high and our min may only be that low, and it may be closer together. So our maxes are not getting as high and our mins are not getting as low. So the peak to trough ratio is getting closer. And I'll show you some better pictures to explain that later. Now, if our peak to trough ratio does change, one of the things you might want to ask yourselves is, has our clearance changed or has our volume changed? If one of those two things change, it will change our peak to trough ratio. And that's because they both affect K, and K is our slope. So for example, if clearance increases, our K increases. If our clearance decreases, our K decreases. And the opposite is true for volume. But when one of these things change, it does affect our peak to trough ratio. So although we cannot fix clearance and we cannot fix volume, we can change our tau. So this is just kind of a recap. When we see changes in bioavailability, it will affect our CSS average, but it will not affect our peak to trough ratio. Volume, on the other hand, will affect our peak to trough ratio, and our CSS average will not. And clearance will alter both CSS average and PT. Instead of memorizing this line, guys, all you have to remember are the two basic equations. If we know the slope of our line, we can see that both clearance and volume affect it. And if we remember our CSS average equation, we know that bioavailability times dose rate over clearance equals CSS average. And again, instead of trying to memorize what does clearance do, what does it affect, if you remember your equations, you should be able to see that clearance is the only one that affects both CSS average and the slope of our line. Now here's an example of a patient who is getting 500 milligrams every 12 hours. As you can see, their CSS average is 2.1, our peak is 3.6, and our min is 1.08. Now say that for this drug that the max of 3.6 is too high, and that causes the patient to be toxic or have bad side effects. That's not good at all. And maybe this min is too low, and now that's not effective. So now our patient is not getting enough drug. What we can do is not change the dose rate, but increase the frequency that a patient is getting the medication to adjust that. And we'll go over here. And remember, the patient is getting 500 milligrams twice a day, which equals 1 gram a day. Now, if we switch that to 250 milligrams every 6 hours, they're now getting it 4 times a day, which is still 1 gram a day. So the total amount of medication has not changed. We're just changing how frequently they're getting it. And by doing so, we lower their Cmax, we increase their Cmin, but our CSS average has still not changed, which is very important to see here. But our peak to trough ratios have. And maybe this is a more desirable effect for our patient. This is just looking real quick about bioavailability. Although it will not affect peak to trough, it does affect our CSS average. And this is just to show you again about those equations, how by knowing your equations, you don't have to memorize what does bioavailability affect, what does volume do, and what does clearance do. By knowing the equations, you can figure that out. And just take a look here. Our peak to trough ratio is the same, even though bioavailability changed, it changed the CSS average, but not our peak to trough ratio. Alright, we'll take another look at volume and affecting our peak to trough ratio. Originally, the patient was getting 250 milligrams every 6 hours. Sorry about that little scribble there. Their CSS max was 2.8, CSS average 2.1, and their Cmin 1.5. By decreasing their volume, that increased their max and it lowered their min, but the CSS average stayed the same. And the reason that is because remember our equations, if we change our volume, we have to change our K, but our CSS average is not affected by a change in volume. See, that's why our CSS average is the same. So if we see all of a sudden that our min is getting lower and our max is getting higher, we know that there has been a change in the patient's volume. And here is just an example of clearance. Like we've been saying, with clearance, it affects both equations, both your slope and your CSS average, and that is why we see both a change in the peak to trough ratio and our CSS average. So when you're asking yourself, when do we change our dose interval, start with the basic question. Is the peak trough ratio clinically acceptable? If that answer is yes, well, don't worry about a thing. Everything's just dandy. But if the answer is no, you have to ask yourself, is it too great or too small? So if your peak to trough ratio is too great, we want to decrease our dose interval and give it more often. So if you were giving a patient a drug every 12 hours, you might now have to give it every 6 hours. And the opposite is true over here. If it's too small, your peak to trough ratio, we can increase our dose interval by giving it less often and go from every 6 hours to every 12 hours. Alright guys, thank you so much for listening. You guys have a great day.